request Dr. Bindu to speak on Kahook dual blade goniotomy. She's a very senior glaucoma consultant at Comtrust Eye Hospital. Thank you, ma'am.
Thank you, Neetu. So we'll just go into Kahook dual blade. Nothing much about the instrument is all known to you. It's just the mechanism here is removing the trabecular meshwork, and the key features here are it is a handheld knife designed to engage and stretch and then excise a strip of a trabecular meshwork. The specialized tip is the one which gives the dual action here. The pros and cons, it's favorably safety profile and fair good results are there, and versatile MIGS. It can be combined easily with cataract surgery. Now when you compare KDB with other MIGS and goniotomy, the GAT and traditional goniotomy, again the trabecular meshwork is cut, torn or incised either within the suture, and trabectome, here again it is removed trabeculum with an electrocautery. Now in KDB goniotomy, what you do is you remove the trabeculum, they say it is without causing significant damage to the surrounding tissue. Especially in trabectome, there is a lot of heat generated. Here you cause less amount of damage to the surrounding tissue. Now I think this part is being covered already. Now the prerequisite, yes, you do want to have a clear cornea, a cooperative patient, especially without any neck issues, and then you have to stop the blood thinners, otherwise the hyphema part will be too difficult to manage. Whom you should not be doing is a patient with elevated episcleral venous pressure, angle neovascularization, or where you're not able to identify the angle definitely. Now we'll just go to the procedure. The first, you have to prepare yourself, know the landmarks, the anatomy of the angle. Yes, you have to be very thorough with it, and like previous speakers spoke about it, always after your phaco, practice the intraoperative gonioscopy and also know about your lenses. So this is what everyone had shown before. You learn to tilt the microscope and see how much tilt you require, and it's better to mark it. And then you have to tilt the patient's head 30 to 40 degrees away from you. And the other thing what you have to do is, your microscope, when you tilt it, you'll have to look from down. So you have to, the eyepiece also, you have to lift it up so that you're comfortable in doing it. The marking which has already been told, and make sure it isn't like to get an on-face view, you align it coaxially, and then first you have a visualization of the angle, and then you try to magnify and view the structures. Which gonio lens? This advantage of Swan-Jacob lens is a one-time investment, and then you can reuse it many times. Though the other lenses are also reusable, but it gets damaged by multiple uses. This is the hands-free, where you get both the hands free to do the surgery, initial stages especially when you're not comfortable. And these lenses are a little bit on the pricier side also. And this is the glucose eye prism. Now first is docking, like I think I'll show in the video itself. So this is like when you're starting from a phaco surgeon, you want to be an MIJ surgeon. Of course, the first will be the tilt of the microscope. Patient positioning away from you. And also ask him to look away so that you get a coaxial alignment. Adjust the eyepiece, and now you're comfortable. And make sure your foot switch is also in a comfortable position. Cohesive viscoelastic over it, over the cornea, and then comes the docking, where you put viscoelastics into the eye. Then first focus the angle first. once you start visualizing it, then you can magnify it so that you get a better view. So this is how you will first start the gonioscopy. This is what we want, the angle which is looking at you, and first view. And this is the other lens, glucose prism, which gives you a wider area. Now what you don't want is a steep angle view. Here it becomes very difficult to do the procedure and to identify the angle structures also. You might not be in the correct plane. So that is what you don't want to. See, you are struggling to get into the trabecular meshwork. This is the steep angle view which you don't want. In the initial stages, that is the learning difficulty. Now what are the other troubleshooters which you encounter during the initial stages? So that is when you are not in the clear cornea zone, which are the limbus, the blood from the section will ooze into the lens, and this can hamper your visualization. And in the initial stage, your hand starts pressing too much and you have the corneal folds again which can hamper it. So that steadiness, and also if you have air under the lens, your visualization becomes difficult. So these are the initial troubles that you can overcome by just doing practice multiple times. Most importantly, you have to identify the angle structures before you go into the procedure. This is the Kahook dual blade. So you identify the trabecular meshwork and then you start stripping the trabeculum. You can just move the lens and the eye so that you can get a wider angle also. And then you turn it and do the other side. So you can extend the angle also, like you can go tilt it and then do the maximum area you can cover it. So that is the collector channels which are exposed. You can put the visco and see if it is. So those are the bleeding vessels from the collector channels. So now we have completed, and then when you wash, you can see the free trabeculum which you have ripped. I just wanted to show the collector channel, but then I injected an air bubble there. See that trabeculum, you can just take a forceps, micro forceps, and rip it off actually. It just comes off. So that's, then you form the AC and the surgery is complete. So the most common complication is the next day you see hyphema and some amount of iritis due to that. I've been doing it since 4 years. I just had one case where the patient had little amount of hyphema, but after 1 week she came with a hypotony and I could see choroidal folds, and this was the ASOCT picture of her. She had developed cyclodialysis cleft, and then I could treat her by just giving atropine and steroids, and it got settled actually. That was one complication which I had. And these are some of our presentations, which one eye underwent trabeculectomy, and the other eye KDB was done. And Another presentation again on goniotomy with KDB. Our pilot study, when we started, we wanted to look whether it is efficacy is there or not compared to the thing. It was effective. Thank you so much.